Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Feel free to ask questions in the chat box as we go along, and they'll be addressed. So today we're going to have a bit of a unique session. We're going to be having Dr. Shima join us, and also Robin Wiseman, who's also a PhD student at Hopkins, and I'm myself as a medical student. So you'll have both perspectives, and we'll be talking a little bit about neuroanatomy basics and their clinical correlations from the anatomy, physiology, and clinical relevance lenses. So you go to next slide. Yeah, so for the anatomy, physiology, and clinical relevance. So we're going to kick it off with the cranial nerves. This is something I see a lot of like reels on my Instagram and TikToks where basically it shows how to memorize the cranial nerves in under 60 seconds. And I remember as a pre-med student, I would be very overwhelmed, but I'd be like, oh wow, I'm learning something like a very relevant medical school topic. But just knowing the cranial nerves is not enough, but it is your bread and butter. So basically, there are 12 that we need to know. Now, there are more than 12, but that's a side discussion. So there are 12 main ones that come from the brain. And so you can see here, this is saying the ventral view of the brain. So I have a box here, and if this is the top of the brain, the dorsal side of the brain, this is the ventral side. So basically, we are looking at the brain from the cranial nerves that are coming out from here. So we're looking at the back or the base of the brain. So we'll kick it off with nerves. Let me pull it up. We'll start off with nerve one, cranial nerve one, CN1, we call it, or CNI, when we're using the Roman numerals. It's called the olfactory nerve. It's responsible for smell. And and if there's a clinical deficit in it, it'll cause an anosmia, which is your inability to smell. In fact, when there's if a patient comes in with whiplash, they may also you may also have it on your differential of having like a cranial nerve 1 deficit as well because of the there may be rapid anterior posterior movement. And then there's cranial nerve 2, which is called the optic nerve. The optic nerve is responsible primarily for vision. It's olfactory and optic are tend to be the easiest ones to remember because they're both, what they say they are, that they do. The optic nerve is responsible for sight and vision. So there could be diseases or deficits with the retina or lens. There could be blood vessel damage, which is common in diabetes, which may cause damage to the optic nerve. And the eyeball is usually affected, but not the nerve though. So the optic nerve tends to be low on the differential list of being like damaged because there are other nerves responsible for eye movement and stuff. So unless there's usually if there's a patient is coming into the ED with trauma, it could be like a fish hook accident, but it's actually affected the eyeball itself, not necessarily the nerve, because that's a little bit deep or kind of towards the back end of your cranium. So because it's deep and safely encased in bone, the optic nerve is a little bit harder to damage relatively, like just from a straight blunt trauma. Whereas if you're comparing it to the olfactory nerve, like just from whiplash, you can have an olfactory deficit because it's just the way that all these nerves are situated. And you guys will learn more about this in cadaver labs. I didn't really understand where all these nerves come from until we actually opened up an anatomy lab and actually looked at it, because seeing is believing. So I'm going to jump ahead from cranial nerve 1, 2, all the way to 8. The reason why is because these are purely sensory or general and special nerves. So we know that we have 5 senses, so that's why I sort of remembered it, 1, 2, 8. So 1 is olfactory or smell, 2 is sight or vision, and 8, cranial nerve 8, or is all called the vestibulocochlear nerve. So if you split it up into 2 words, vestibulo means vestibular, which is referring to balance, and then cochlear is auditory. Cochlea, if you remember cochlear implants, like from in your ear, that's related to sound. So that means that the vestibulocochlear nerve is related to balance and sound, or hearing and balance. So if there is a deficit in this nerve, in the cochlear aspect or the auditory aspect of this nerve, then it'll lead to deafness. And if there's an issue with the balance part of the vestibulocochlear nerve, then it would lead to dizziness, falling, right? Because you don't have balance anymore. And also some abnormal eye movements, because when you're dizzy, you're not able to actually focus on the finger. There are various ways that we check for these cranial nerves during a neurophysical exam. but we'll get into that in incoming weeks. And also, if there's a deficit with your cranial nerve 8, it could lead to nausea and vomiting, motion sickness, and also a vestibular and visual mismatch. And what that means is basically the vestibular, basically your balance is just mismatched with your vision. If the room is spinning, that could be a sign as well if you're feeling dizzy and out of balance. Now I'm going to switch gears into my motor nerves. So I'm just starting with the relatively easier ones to remember, cranial nerve 11, which is called the accessory nerve. All it does is innervate the muscles, the sternocleidomastoid muscle and also the trapezius muscle. Basically, it helps you keep your body stable, and basically if there's a deficit, one side tends to like droop down, and you can tell that there's an injured side because it's not able to lift up your arm. Upon nerve injury, basically your muscles waste away, and that means that your muscle mass diminishes over time. So that's how, because you're not using that side as much, and if you don't use it, you lose it. So that's why muscle mass decreases if the accessory nerve on one side. Remember, we are bilateral beings, so the nerve might be damaged on one side, not the other side. That's a very interesting thing that would come up on a lot of exams in med school, where there's this side that's deficit, but how would that actually affect it in the real world, like, because sometimes you have to go opposite, sometimes you have to go the same. So that's a sidebar, but basically if your accessory nerve is impaired, it impairs your head turning, so you can't turn it side to side because that's what your sternocleidomastoid muscle does, and also impairs your arm movement. Then there's cranial nerve 12, which is called the hypoglossal nerve. The hypoglossal nerve, if you have taken Latin, glossa means tongue in Latin. So it's a skeletal nerve which is responsible for the motor innervation of your tongue. So if I'm able to move my tongue right now, that means my hypoglossal nerve is intact. But if it is deficit, if there is an injured side of that nerve, then the tongue would deviate to the side of the inactive muscle. That's how you're able to tell which side exactly the hypoglossal nerve could be damaged. So you could see a patient, if you tell them to take their tongue out, you go, ah, and then if they're not able to go straight, they go like this to the left, or my left, that means that is the side that it is damaged. So that's interesting to think about. It's a clinical correlate. And that these are all things that you'll learn in med school. I'm just giving you the very basic or interesting things, because I remember as a pre-med, it was very hard to see the other side, like why I was learning all of these things. And just learning clinical deficits was easier. So now we're going to get into the cranial nerve 4, which is called the trochlear nerve. The trochlear nerve is also a motor nerve, which is responsible for eye movement, specifically the superior oblique, I believe. So the trochlear nerve, if that's damaged, it could be damaged by inflammatory diseases. It could be compressed due to an aneurysm. And so there's actually even like a risk to the trochlear nerve during like midbrain surgeries because of the small and delicate size of this nerve. And it has a very long intracranial path because it has to go all the way to your eye to help one of the muscles in the eye actually help you move it. The abducens, or cranial nerve 6, is also responsible for motor movement of the eye. And if it's impaired, you're not able to look laterally, so you can't look side to side with that eye muscle. It's very interesting how a lot of the cranial nerves are related to eyes, so that's why I kind of grouped my eye cranial nerves together. So damage to the abducens nerve is also one cause of strabismus, which basically means the inability to direct both eyes toward the same subject. So what that basically means is one eye sort of deviates to one side. Even if you're looking straight ahead, or you're telling the patient to look straight at me or look at my nose, you can see one eye in strabismus sort of deviating to one side. And then here's our final specific eye-related nerve, the ocular motor nerve, or cranial nerve 3. And basically, this innervates the muscles of every other muscle of the eye. Now, to give a bit of context, there are multiple muscles that are responsible for eye movement because it's so intricate. You want to be able to invert and extort your eyes and also move them up and down, and you want to be able to roll your eyes too. So that's why we have a lot of muscles for them, and those muscles are innervated by specific nerves. So the ocular motor nerve innervates everything else basically, and is responsible for the muscles moving the eye, and also it has a bit of parasympathetic action, the parasympathetic to eye smooth muscles. And so how this one can get damaged is sometimes aneurysms of the internal carotid artery, which we will learn soon. But basically, an aneurysm can press and paralyze the nerve essentially. And so all ocular deficit or all ocular motor deficit symptoms should be assumed as urgent unless the possible as a possible aneurysm until they're determined otherwise. Because if there's an aneurysm and that's compressing and paralyzing the nerve from the internal carotid artery, which is a very major artery, and one way you can clinically tell is if there's like eye symptoms that your eye is deviating to one side or the other, then that is considered an emergency unless you're able to tell, okay, no, there is no aneurysm in this internal carotid artery, which is very close to the aorta. And if the internal carotid artery is not just responsible for your eye movement, it's life-threatening. So that's a very important clinical correlate I try to remember with ocular motor nerve deficit, sort of just suspicion in my differential. Now we're going to switch gears into the basically these are both sensory and motor nerves. So cranial nerve 5 is called the trigeminal nerve. They're responsible for mastication or chewing. And they're also sensory for the face. So there's actually like branches of that nerve called the 5-1, which is ophthalmic, maxillary, and mandibular. So these are things you have to remember, because if there's damage to just the mandibular division of the trigeminal nerve, that will impair your ability to control your jaw on the injured side. So you'll see patients with a jaw that's sort of injured or moving on one side. But yeah, they're primarily mastication muscles and sensory to the face. So if I'm touching, so sometimes during the neuro exam, we touch patients with soft touch and sharp touch. And if they're able to feel all, so I have to touch all these areas, that means that their trigeminal nerve or cranial nerve is intact. And if they're able to move up and move their jaw around, of course. Now, our next both mixed, I guess you could say, nerve that's both sensory and motor nerve is called the facial nerve, cranial nerve 7. This is a skeletal muscle responsible for, well, it innervates a skeletal muscle responsible for muscles of facial expression. So if you're able to smile, it's responsible for a lot of those muscles. And also part of the tongue taste. Basically, the tongue there's not just one nerve that innervates the tongue taste, there's two. So 2/3 of the anterior part of the tongue is responsible or innervated by the cranial nerve 7, which is a facial nerve. And then there's also some general sensory, very minor functions of that facial nerve, but I just remember facial nerve, facial expression muscles, and tongue. The facial nerve also has divisions, which you'll learn about once you're med students. The divisions are called the temporal, zygomatic, buccal, mandibular, and cervical. So I'm sort of just saying this at the top of my head because we had to really drill this sort of stuff down. The reason why we learned this type of anatomy is because there are clinical correlates associated with each division, because we just have to know so that we can treat our patients the best way possible. And now our last two nerves, cranial nerve 9 and 10. So cranial nerve 9 is the glossopharyngeal nerve. The glossopharyngeal nerve is a sensory and motor nerve as well, and it's sensory and also motor to the pharynx muscles, and also sensory to the rest of the tongue. So remember I talked about how the facial nerve has 2/3 or most of the tongue taste. Now the cranial nerve, that was cranial nerve 7, now cranial nerve 9 also has part of that tongue, that 1/3 remaining tongue part. Now, if there's a deficit in cranial nerve 9, there is actually difficulty swallowing from paralysis. So how I always remember this is it's a glossopharyngeal. So glosso, again, tongue. Pharyngeal means pharynx. So that's how I remember there's sensory to the posterior 1/3 of the tongue and motor pharynx muscles. So if there's a palsy or a deficit, a patient will come in with difficulty swallowing. So if I was asked, for example, okay, a patient comes in with difficulty swallowing, and if I'm asked a question, which cranial nerve do you suspect is affected? Well, and then they also mentioned the posterior 1/3 of the tongue. That's how I'll be able to know out of all 12 cranial nerves, it's probably cranial nerve 9 because they're having difficulty swallowing from paralysis of the pharynx musculature. Now, our last nerve, I'll save the best for last the vagus nerve, cranial nerve 10. Now, the cranial nerve 10, the vagus nerve, you might have already heard about it, but the vagus nerve is responsible for basically living, really, because they're responsible for muscles of the larynx. They're parasympathetic to the smooth muscles of the thorax and the abdominal viscera. And without that, we wouldn't be able to breathe. So we need that ability to breathe to function. So I always remember the vagus nerve is really the most, one of the most, all of them are important, but this is also a very important nerve because if the vagus nerve is damaged, then that's a literal emergency. That it's a threat to life. Um, it has skeletal and visceral motor function, and also visceral, general, and special sensory function. So vagus is both also a both a sensory and a motor nerve. So let's sort of recap which ones are sensory, which ones are motor, and which ones are both. So cranial nerves 1, 2, and 8. I went in that order for a reason. All three of those are just sensory nerves. The olfactory, optic, and vestibulocochlear. And then cranial nerves 11, 12, 4, 6, and 3, they are the motor nerves, just exclusively motor nerves. And in both sensory and motor are known as the trigeminal, facial, glossopharyngeal, and vagus nerves. So I hope that was a good rundown of the cranial nerves and why we need to sort of understand these nerves and how each nerve has its own sort of a very important role it plays, essentially. So I hope that was helpful. Of course, there are things to learn about that, but Robin, do you have anything else to add?
Yeah, quickly. So if you're interested in things like neurodegenerative diseases, the vagus nerve is important for this gut-brain axis that people have been studying. We think that there's transmission of like Parkinson proteins from the gut to the brain. So that's something cool to look into if you're interested, which makes the vagus nerve even more interesting. And just a quick like clinical relevance question. So you talked about anosmia, and one of the diseases that we've all heard a lot about in the last 4 years, obviously, is COVID-19. And one of the symptoms
Mhm.
that people have is a loss of sense of smell. So do you have any hypothesis about where that symptom is coming from?
Really, I have not done my research on that, but that is what I was thinking at as well. Like the loss of the sense of smell and taste, that is similar, that is anosmia. Is that relevant to a cranial nerve? That the olfactory nerve being damaged. Now, so far, I asked my professor this, they said no, it's not like a nerve because there are many other causes of anosmia. It could be like a different type of brain damage, or it could also be congestion, and it could be like flu-like symptoms. So really, there's still research being done on that. I would say that's a really good question, and there's still research being done on that. I'm trying to check PubMed right now. But yeah, no, because the sense of smell largely comes back, it either heals itself, but I don't think it's a nerve-related issue. It's like considered olfactory dysfunction, as I'm reading right now. Smell loss lasts only a few weeks. But only 12% of people with COVID-19, it persists in the form of like a chronic type of loss of smell. But now there isn't much about it, like in terms of like, no, it's considered olfactory dysfunction and it is a sensory nerve. So you could say it is damaged, right? But I think it does heal, or it's not like a damage that persists for more than 12 months because it heals. But do you know anything about that? Like, I'm just curious.
Yeah, so I don't think we really know. I went to a neurovirology conference this year and people were sort of talking about how this is an interesting phenomena and they don't know if it's like inflammation caused by the virus and like the olfactory bulb. And so like the hope is that that's not the case because there's sort of like a one synapse distance between the olfactory bulb and your hippocampus.
Mm-hmm.
You don't want COVID-19 to be setting off some sort of like widespread neurodegenerative process in the brain, but it could be like a much more like harmless thing. We just don't know yet.
Exactly. And that reminds me, like, there are a lot of patients who've been reporting symptoms of brain fog as well. So, of course, it is one synapse away from the olfactory bulb. And yeah, more research is to be done on that for sure. Good food for thought. Thank you. All right, now we're going to switch gears into the next slide. Yes, the ventricles of the brain. So I didn't know this until starting medical school, but did not know that we had ventricles in our brains. All I knew was that there were arteries and veins that were circulating blood, and I thought that was the only fluid that we had. Now, yeah, I knew of cerebrospinal fluid. I just didn't know it went all the way to the brain. But that makes sense because the spinal cord is attached to the brain, which is part of the CNS, the central nervous system. which is something you do need to know for the MCAT, the central nervous system. So it is all connected. Essentially, there is this series, and you can see here it's color coded, but these are the ventricles of the brain. And so I had this like anatomy software which would show me, and I would always like I would maybe I could screen share it now. And Robin, you can go ahead and talk a little bit more about the importance of the ventricles of the brain while I pull that up.
So you're probably all familiar with the fact that there's really tight control over what gets in and out of the brain. So you've got these tight junctions in the blood-brain barrier to protect your brain from toxins and even biological molecules that don't need to be in the brain. But it does need some mechanism to bring in nutrients and to dispose of waste. So these fluids, and particularly like the CSF, is really important for these homeostatic processes. And then, like medically, we're able to take advantage of this pathway because some of the diseases that we've been trying to treat, like Huntington's disease, one of the things that's in clinical trials are these antisense oligonucleotides. So you're actively targeting the pathogenic mRNA molecules that are making these proteins. So you do these intrathecal injections. So you inject it right into the CSF so that it's transported up into the brain rather than having to get through the blood-brain barrier.
No, thank you so much, Robin. And if I screen share, it'll stop screen sharing for this. But basically, if you search up like just a 3D model of the brain's ventricles, it's very, very fascinating. Just understanding like how intricate it is because we learned a lot about the fourth ventricle. You can see here why is that like a junction type ventricle here. The reason why is because that one is a very fragile type of ventricle and things can happen there. And if that gets clogged up, and I'm using layman terms, if that gets damaged or clogged, or you're just not able to, the flow is just not proper, it really leads to many, many clinical complications for patients. All right. Now we're going to touch a little bit on the blood flow of the brain. Now I highlighted the circle of Willis. This is a very important buzzword, circle of Willis, and that we'll hear about a lot in medical school, but I didn't learn about this for the MCAT, so you guys don't have to worry about it necessarily for now. But as I mentioned previously, the internal carotid artery, the middle cerebral arteries, basically the circle of Willis is just this ring of vessels that connect to the anterior and posterior circulations of the brain. This ring is, and it's called a circle, right? Because it's all interconnected, which is very fascinating about the brain, which is very unique to it. The ring is bounded anteriorly by this by a single anterior communicating artery, we call it the ACOM, which connects it to the bilateral anterior cerebral arteries. Now, I know this sounds like a lot of garble because I'm saying a lot of words like middle MCA, middle cerebral artery, posterior communicating artery, we call it the PCOM. But these are all incredibly clinically relevant. So that's why the anatomy is so important to know. Now, before I be like, what is the purpose? I get it, like there are arteries, but no, you have to know exactly like where exactly the patient's aneurysm occurred. Did it happen in the PCOM or the ECOM? Because that'll lead to different clinical correlates. Because we'll learn with Dr. Chima, and we'll look at a couple of CT scans of what actually it looks like if the PCOM is clogged, you could say, versus the ACOM. So the circle of Willis is just this amazing, amazing thing. I'd highly recommend just searching and learning more about it, and you can get lost in this sort of this this whole basically. I remember just spending a whole day just learning about the circle of Willis. It was very fascinating. Okay, and now we're going to talk a little bit about basically you might have already seen this. It is basically inspired by a homunculus, which basically shows you like which part of the brain is responsible for which part of the body in terms of sensory and also sensory blood flow, just overall function. So I talked before MCA, AC, and PCA, and now I'll define these acronyms. The MCA is called the middle cerebral artery. And essentially, the middle cerebral artery. Now, I like this picture, and I wanted to show it to you. So yeah, you know exactly where you are in the brain. Just knowing where you are helps a lot. So if you're looking at the left picture, you'll see here it's pointed at the middle part of the brain, and then it's taking that transverse cross section of it. Now, I would always be wondering, why did we take organic chemistry? It's sort of to understand where you are, like just understanding molecules and their orientations will help you a lot in understanding CT scans and radiology images to just knowing where you are is very important. So the middle cerebral artery, as I was saying before, is responsible for the upper limb, the face anterior cerebral artery is responsible for that. And well, actually, no, the middle cerebral artery is responsible for the upper limb and the face. The anterior cerebral artery is responsible for the lower limb. So if you're looking at the hip, knee, and at the top part, that's called the anterior, right? Anterior means top towards the top. So you can see it correlates the anterior cerebral artery. If it's towards the top, that's responsible for the lower limb. And you can see it's pointing to the hip, the knee, and the toes, the feet. And then the posterior cerebral artery. Now, the posterior cerebral artery is, let me look for it, is responsible for vision. So this is important because now we have the occipital lobe back there. So the occipital lobe is towards the back of our brains. Then we need a posterior cerebral artery. So I like that these arteries are also sometimes they make it easy for us. They name it based on where they are. So it makes sense that if I'm asked like a posterior cerebral artery, what is that? What is the function of that? Well, or like what does it benefit, you could say. So the posterior cerebral artery, PCA, it supplies blood to your occipital lobe, and because it provides blood to the occipital lobe, it's able to function properly. And what is the function of the occipital lobe? It is vision. So that's a good like a two-step sort of reasoning into if I'm told, oh, there's an issue with the PCA, then that means that there might be vision problems. So we're sort of looking at this problem sort of reverse. But if a patient comes in with vision problems and you're asked to give a differential diagnosis basically means a list of things that could be going on, a list of problems. And it can be an unlimited list. They ask us between 3 to 5 in class, but basically like if a patient comes in with vision problems or if they had sudden onset of blindness, maybe check if they have an issue with their PCA, do a CT scan, check if there's some issues with the posterior cerebral artery. Because if there's no blood being, as you know, we need blood for everything to work, from our brain to our heart to everything. So that's my little ramble on the PCA and vision. It might be relevant for our certification quiz later today, which is why I emphasized it. Hint, hint. All right, now as for our next slide, this will get more relevant into MCAT things. Basically, the cells of the nervous system. This is relevant for both for the MCAT and also the USMLE Step 1. We need to orient ourselves again, like I said before, there is the CNS, central nervous system, and PNS, peripheral nervous system. So we are focusing today more so on the central nervous system, which is why you can see here. But you can also see why we're focusing more on it because there's more cells of the nervous system beyond just neurons. Neurons are called brain cells, but I learned that there are other types of quote unquote neurons or brain cells or cells of the nervous system essentially. So I'll go over each one's function pretty briefly. They will be discussed later today too, but basically the glial cells, they support neurons. Microglia, they are the sort of resident cells of the brain they regulate brain development, the maintenance of the neuronal networks, and they also help with injury repair. And the microglia, what I like about them is that these are like basically phagocytes or immune cells, and they're the most abundant mononuclear phagocytes in the CNS. So microglia are very important. And I also showed there's a picture here of a neuron and myelin sheath. So that's pretty important to remember. There are many other types of glial cells. Essentially, their job is to support the neurons. The macroglia, they include the astrocytes, oligodendrocytes, ependyma. There's microglia. Um, there's a lot you can say about these. So I don't want to overwhelm anyone, but basically the astrocytes, they're important for supporting neurons too. They're found in the CNS, specifically in the gray and white matter. They basically remove excess neurotransmitter. They're also responsible for repair of the body and also, I believe, scar formation. And astrocytes are pretty important because they're a major part of gliosis. Basically, in terms of when there's inflammation, there are astrocyte markers in the brain, which help you understand that there is inflammation going on. And that's relevant for different types of diseases in HIV patients. There's also microglia. They're basically the macrophages. Now, a macrophage is something that sort of eats other cells and deletes waste products. They differentiate into larger phagocytes if there's injury and inflammation. Um, And yeah, I think that's all I'll say about that. Well, Schwann cells, they're part of the peripheral nervous system. They myelinate those axons of the peripheral nervous system. And myelin, now, we might already know what myelin is, but just to review, because it is very important to know, myelin is composed of lipids and proteins. They actually increase the speed of the impulse propagation in an axon. So they're basically like an impulse can still occur without myelin, but myelin, we need myelin so that it can go faster. And there's this term called saltatory conduction that improves with myelination. When there's demyelination, there happens to be disease. So that's not an ideal scenario, but there is some math that goes behind it. But basically, when there is myelin involved with the axon, it increases the conduction velocity, which increases the length constant. And after all the calculations, basically it just means speed go fast, which basically means your brain will work faster with myelination. And I think that is the most efficient way. And I think we know some demyelination diseases like multiple sclerosis, and sure, patients are functional, but it's just not as quick. We need that myelination for quick action potentials, which we'll go over. But yeah, I think that's my little bit on myelin and microglia. Robin, unless you wanted to add anything else.
I mean, I can quickly add, I think we sort of think of neurons as like the stars of the brain, but glial cells are super important. So your population of nerve cells and neurons is pretty conserved throughout your lifetime, but the microglia cells are, and microglia and astrocytes and all these supporting cells are much more active. So when people develop like a cancer of the brain, like you may have heard of glioblastoma, it's usually these more active cells that are dividing more. And also in a lot of like pathologic processes you see in the brain, like you could see that the microglia are not doing their function and clearing anymore, or they're trying to respond to a threat, but they can't turn themselves off. So they're causing this level of inflammation that's causing long-term issues. Yeah, so I think these cells are really interesting when you're thinking about like pathology of the brain.
No, thank you for mentioning that for sure. We learned there are so many types of brain cancers that can happen. But yeah, but yeah, that's all we'll say on that for now. When you're all med students, you'll understand why my brain goes quiet when I think about brain cancers. There are a lot, and it's very unfortunate pathologies for our patients, but that's why we're here to treat them. But now we're going to talk about the neuron action potential. I've been learning about this for many years now. I was also a neurobiology major in an undergrad, so this was really like they really taught us this very well. But it's also on the MCAT, so this is very relevant to know. Now, I never really understood. I just understood. Okay, so this is just how neurons work. We understand that this is the biochemical basis of how the neurons sort of function very fast, how they go, how they just basically propagate signals through their axons. And I thought that was it. I thought that was the only relevance for the neuron action potential. But just for a review, I'll talk a little bit more about this neuron action potential. This is a good review for me too. But let me reorient. Okay, so basically, let's start off with the key facts about the action potential. So basically, at rest, neurons just have this voltage of negative 70 millivolts, and that's maintained by a leakage of potassium out of the cell. And so to depolarize this action, because look, these are neurons at rest. Now, if you want an action potential to occur, and you want to go from negative 70 to plus 40, right, in millivolt or just voltage, you need to depolarize, in order to depolarize, we need our sodium channels to open, and that allows sodium to rush into the cell and raise voltage. Now, how I remembered it, and it may not be completely accurate because I don't have that chemical lens. I just remember that sodium is positive, so those positive charges from the sodium cause depolarization and it increases the voltage. If I'm already at a negative voltage and I'm putting in positively charged ions, the voltage will go up if there's more sodium going in. So that allows sodium into the cell and it raises the voltage. Sodium channels will then open along the axon, along our membranes, and that will cause propagation of that signal. And then at the axon terminal, the calcium channels tend to open and it's triggered and once a calcium channel is open, that triggers release of neurotransmitters, and then vesicles fuse with the membrane, and that causes exocytosis. That's more of a biology lens on the action potential. I know the MCAT focuses more on the chemical lens of the action potential. That's basically it. Now to repolarize, you'd instead of the sodium channels leaving, the potassium ions leave. That causes repolarization to be much faster, and then that leads to a hyperpolarization, and then eventually we're restored to a resting state. So I think that's and that resting state happens after a brief refractory period, which is that basically that little hump below the -70 line. That's called the refractory period. So I hope I covered most of the points of the action potential. I know it was a little bit briefer and a little bit less MCAT type, but I would say like those are the most important points we need to know in medical school. So, you know, I was thinking like, okay, I know the action potential, that's all I need to know for this exam, but no, it's relevant for our patients still. And if you go to the next slide, we'll see here why it's important because in the real world, and this is a screenshot taken from the Kaplan biology book from last year, but this is a toxin. There's a toxin called tetrodotoxin, TTX. It's found in pufferfish, which is basically it's like delicacy food in Japan. And I've had too many questions maybe about TTX, like basically what it causes. So if it basically blocks voltage gated sodium channels. So essentially, like if this fish is not prepared properly, it can cause the blockage of these voltage gated sodium channels. And remember, if there's no if there's no sodium coming into the cell, there will be no depolarization. That means there will be no neuron action potential, which means that the neurons are just not going to fire. They're not going to operate properly. And that basically can cause death because if these are now it can cause death all over, but essentially, like remember we talked about the vagus nerve, breathing. Like if you are not able to breathe, if your diaphragm muscles are not able to move, and we need that, you're not able to innervate that diaphragm, you cannot breathe, it'll lead to paralysis of that muscle. It won't move anymore, and then you're not able to breathe, and that leads to death, rapid death, actually. So that's why like chefs have to be really like certified in order to prepare this puffer fish. Now, but honestly, after learning about this, I just don't want to eat pufferfish at all. Like I'll just eat sushi or tuna. But I know like to be culturally sensitive, of course, like it like we will see patients from all over, right? So a lot of questions that come up are like, okay, this patient from Japan. So it's sort of to kind of prime us into thinking, okay, let me think a little bit about what their cultures are like or what they eat normally. It's not like we're all eating the same thing. So I like that. It's a good diversity lens to have. And pufferfish is still eaten in the States too. It's a melting pot here. So it's relevant. And this is the most direct relevance to the neuron action potential beyond just, oh, sodium go in, potassium go out. Now, there's this really good mnemonic I learned when I was studying for the MCAT called a 3-2-1 Nokia. It's weird at first, but it's good. If you Google on Reddit, it's really relevant. Basically, 3-2-1 Nokia means three sodium out. So three NO. So three sodium out. The N means sodium, O means out. So NO no from Nokia. K in. So remember, potassium goes in. So that's two potassium going in. So 3-2. So that's why 3-2-1. And one, and then the A at the end is ATP, which is one ATP molecule. So that's 3-2-1 Nokia. And that's actually to maintain resting membrane potential. So that's how I know in order to maintain resting membrane potential, I need three sodium going in, two potassium going out, and that's how I know I'm at rest or that -70 millivoltage. But yeah, I think that's all I had. Let me check with Dr. Chima on her slides. She'll talk a little bit more on like the lobes, some a little bit more detailed, I would say. And yeah, Dr. Chima, thank you so much for volunteering your time.
Very good morning, everyone. Thank you, Minahil and Robin. Really appreciate. We have two astute students with us. I really appreciate, Robin, your time. You know, Robin is a PhD student applying for medical school. I wish you best of luck, Robin. And Minahil, thank you for talking about neuroanatomy briefly. So let's talk. Now, I would like to go over briefly anatomy and histology and briefly about the functions, and then we'll clinically correlate the case. We will have a one case study about it, why we are getting these anatomy, physiology. So you have a basics to understand, and then you can correlate clinically. So let's go over pretty quick about the anatomy. So first of all, the human brain can be divided into different parts. It's called cerebrum, cerebellum, and brainstem. So let's talk about the cerebrum. It's the largest portion of our brain. So major portion of the brain is called cerebrum and divides into left and right cerebral hemisphere, both of which have numerous folds. And there's a convolutions in between as well on the surfaces. So we will explain these terms. What are these terms called? So between these convolutions and ridges known as the gyri, and the small grooves in between, you can see on this slide, the small grooves you can see, these are called the sulcus or sulci. So I told you two right cerebral hemisphere and the left cerebral hemisphere, and both of which are covered as a cerebral cortex. And there is a gray matter and white matter. I hope you're already learning when students who are in the neurobiology undergrad, you know that. And then they are together by the corpus callosum. And whereas the left hemisphere controls the speech and abstract thinking, and the right cerebral hemisphere controls the spatial thinking. So let's talk about the lobes of the cerebral cortex. So cerebral cortex has 4 lobes: frontal lobe, parietal lobe, temporal, and occipital lobes. And all these 4 lobes have different functions. They're the high cognitive areas, high cognitive functions. The frontal lobes present directly behind the forehead. So behind my forehead is the frontal lobe. And hold on a second, please. And frontal lobe basically is the largest, one of the largest lobe among all 4 lobes. And the primary is the main function of is the controlling the language as a motor function. As one of the student Minahil mentioned about she was showing you all the homunculus, how it looks like. You can see all the movement is a motor function. Why is motor function? So you can see, you saw on the homunculus, the legs and arms were on that in the anatomy then when she was showing it to you. And most importantly, various cognitive processes are going on in the frontal lobe, like including the self-awareness, our mood, our memory, our attention. So these are all highly cognitive, and most importantly, both social and moral reasoning is in the frontal lobe. So within the frontal lobe, there is a Broca's area as well, which is responsible for our speech production. So this is the basic I'm teaching you. And then the parietal lobes, who can found near the center of the brain between the frontal and occipital lobe. So you can see in this diagram, the parietal lobe. So it lies between the frontal lobe and the occipital lobes. They are responsible for the different sensory and memory functions. And then you can see over here the temporal lobes, which is commonly referred to as the neocortex as well, and is located close to the base of the skull. You can see over here cerebellum, we'll talk about it, but let's focus on the temporal lobe. So within the temporal lobe is the Wernicke area. So I told you in the frontal lobe is the Broca's area, and the temporal lobe is the Wernicke's area. So what is the function? So it allows individuals to understand both the spoken and written language. So in addition to that, they can process the processing of the speech. The temporal lobe also processes the sensory information that contributes to the retention of the memories, languages, and emotions as well. And the fourth and the final lobe of the cerebrum, the occipital lobe, is so small. You can see over here in the diagram, the smallest lobe of the cerebrum, and forms it's also called the caudal part. So again, terminology, cranial and caudal. So the caudal part of the brain composed of, and the primary function of the occipital lobe is the interpretation of the visual information. So whenever we see from the eye, all the images go back in the occipital lobe. And pretty quick talk about the cerebellum. This portion sitting here is called cerebellum, is the largest of the hindbrain. And upon reception of the motor information from the both cerebral cortex and the musculoskeletal structures of the body, the cerebellum basically coordinates these signals to maintain our gait and the posture of the human body while we're moving around. So when there's a gait instability, sometimes the cerebellum is the main function of the cerebellum as well. And the cerebellum itself does not initiate the muscle contraction. Basically, it aids in the refinement and accuracy of the motor function, motor activity of controlling the muscle tone, and all this is the function of the cerebellum. All right, so let's go talk about the brainstem briefly. So brainstem is this portion, and the cerebellum and the spinal cord are connected to the
10 o'clock.
cerebral hemispheres by the brainstem. And brainstem has 3 main parts: midbrain, pons, and medulla oblongata. So these 3 portions make together as the brainstem, and it's classified as the 4 distinct functions, and is included the diencephalon. And diencephalon is the most, you can say, superior portion of the brainstem, and it's further subdivided in 4 portions. I will not go in details, but I will briefly: epithalamus, subthalamus, hypothalamus, and thalamus. So what is the function of the thalamus? So thalamus basically, I think we can go to the next slide so you can see the other. Yes, okay. So now you can see the medial portion of the cerebral hemisphere, one of the cerebral hemisphere. So the thalamus is basically the largest portion of the diencephalon. And what's the function of it? Basically, it serves as a relay point for all the sensory information that enters the cerebral cortex, and eventually it gets transmitted to the cerebrum for the processing. So hypothalamus also processes incoming sensory information. So hypothalamus processes the sensory information, and all the information processed by the hypothalamus that is derived from the autonomic nervous system. All right, so pretty quick, let's talk about what's the function of the hypothalamus. So what does hypothalamus do? So basically, it maintains the eating habits, sleep patterns, and in addition, maintaining the body temperature. And also, there's the secretions of, we'll talk briefly about a neurotransmitter at the end, but of course, there's secretions of pituitary gland, that many hormone released from the brain, there's a lot of chemical released from the brain, and then which develops from a downward extension of the hypothalamus and is controlled by the hypothalamus. But I will not go in much detail about it. So pretty quick about the midbrain, as we mentioned, talk about brainstem has a portion of midbrain, medulla pons and medulla oblongata. So what does the midbrain, what's the function of the midbrain? It basically connects the diencephalon to the pons, and it controls the ocular motion. So as you guys were learning about the cranial nerves, so many cranial nerves arise from midbrain as well. So they control the ocular motion. And whereas the pons is involved in the regulation of the eye movement and the facial movement. And the reason is the brainstem is very important because all the cranial nerves origin is from the brainstem. And God forbid if there's damage to the brainstem. So how we assess it? So the cranial function we can assess clinically. How there's a damage. Is the brainstem portion is damaged? Which part of the brainstem is damaged? That's why cranial function is very important clinically, how we can assess clinically. Okay, all right. So let's pretty quick, medulla oblongata. So which is located between the pons and the spinal cord. And therefore is the most inferior portion, is the most inferior, of portion of the brainstem. It controls the autonomic functions such as breathing or blood pressure, cardiac rhythm, and the swallowing. So these are all controlled by the medulla oblongata. So I would like to mention, God forbid, there's a brain death of the patient in a clinical setting is declared when there is a significant destruction of the medulla oblongata. So, you heard the term brain death, brain is what happens. So how we evaluate. So this is how we say that there is a significant destruction of the medulla oblongata. So briefly, I will go over pretty quickly again. Frontal lobe, located at the front of the brain, responsible for the high cognitive functions like self-control, memory, emotional expression, and also essential for the communication abilities. Temporal lobe, most commonly associated with the processing auditory information and encoding of the memory. And then parietal lobe, primarily responsible for receiving and processing sensory information such as touch, pressure, heat, cold, pain. These are all the sensory information related in the parietal lobe. And occipital lobe helps with the visual processing and mapping. And there's another, I want to talk about the limbic system. Can we go to the next slide, please? All right, so limbic system. So this is the part of the brain involved in our behavior, our emotional responses, our emotional memory, our social recognition, there are many parts, amygdala, limbic system, there's cingulate gyrus there. So part of the limbic system are the limbic cortex, cingulate gyrus, hippocampus, amygdala, thalamus, hypothalamus. So I will go over pretty quick about the histology of the brain. Then we'll talk about the case study. So let's please move to the next slide. So this is again the limbic system. We talk about these are parts of the limbic system. And now the histology. So histology is when we see the brain cells under the microscope. So most importantly, brain tissue is composed of the neuronal cells, glial cells, and endothelial cells. And neurons is basically the main important function of the cerebral cortex. So neurons typically have a large pale nuclei with a prominent nucleoli. And the non-neuronal glial cells lies in the gray matter. I will talk about gray matter and white matter of the brain, cerebral cortex. So it includes the oligodendrocytes, and that is composed of a pretty quick, there's a hyperchromatic area, there's a round nuclei, and there's abundant clearing appearing cytoplasm around it. And then there are astrocytes. The astrocytes are basically the paler in color. They have more elongated nuclei, and usually they have a scant cytoplasm. So in oligodendrocyte, I talk about there's a clear appearing cytoplasm, but in astrocytes, there's a scant cytoplasm, and they are the microglial cells. Okay, so pretty quick, I'm going to go over the blood supply. And so brain receives the blood flow from two main sources. One is the internal carotid arteries. So internal carotid artery basically arise at the point of the neck. So over here, even when you clinically, you can palpate the carotid artery here. So which arise at the point in the neck where the common carotid arteries bifurcate, and the other arteries are vertebral arteries. So these are the main arteries that supply the brain. And we already talk about the circle of Willis. So let's go over one by one. You can see over here, the frontal lobe, so main arteries, I want to talk about the anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery. So you can see in this diagram, so this portion yellow is supplied by the anterior cerebral artery. This part, middle cerebral artery, and this section is supplied by the posterior cerebral artery. So this is the medial view. It's the lateral view, sorry. And this is the medial view. So I told you there are two cerebral hemispheres, right and left. So when we make them apart, so you will see the medial aspect of and you will see, excuse me, all the limbic system here. And you can see over here, most portion on the medial side is supplied by the anterior cerebral artery. And this blue portion is supplied by the posterior cerebral artery. So why we're talking about? I want to discuss the clinical case. So let's go pretty quick. Yeah, again, this is a diagram of the circle of Willis. Please go back. Yeah. So this is again, you can see the circle of Willis, anterior cerebral artery. You can see what this is the internal carotid artery. We talk about the main arteries, the internal carotid artery and vertebral arteries. And then you can see anterior cerebral artery, middle cerebral artery, and posterior cerebral arteries, and how we already talk about the circle of Willis. So let's talk about, now we will correlate what is CVA. You heard the term stroke, right? Patient had a stroke. So what does CVA stands for? So cerebrovascular accident. So that's the reason I brought up first of all, the brief anatomy, then the blood supply. So vascular supply, blood supply is basically the vascular supply of the brain. So cerebrum, so cerebral vascular accident, right? So that's the reason I brought up brief anatomy, then blood supply of the brain, so we can understand the terminology of CVA. So cerebrovascular accident basically is referred to or other terms of stroke, when there is an interruption in the blood flow to the brain cells inside the brain. So you have seen the anatomy, you can see over here. So what are the causes? What can cause it? So when there's an interruption of the blood supply in the brain, so how are we getting oxygen? So we get oxygen via blood. So when there's a cut down of the blood, so what happens to the brain cells? So brain cells are not getting enough oxygen. So they are deprived of the oxygen, and brain cells start dying. So that's how the stroke symptoms start appearing, and it's an emergency, and we need to take care of it right away. So basically, stroke is a disease that affects the arteries leading to and within the brain, inside the brain. They're supplying the cerebral cortex. And it is a fifth cause of death and leading cause of disability in the United States. So you have to pay much attention that is a leading cause, and we have to pay much attention how we can prevent it. There are preventive measures, and God forbid if someone has stroke, how we can help. So basically, there's different types. I want to talk two main types of stroke. There's a cryptogenic, thromboembolic, but I want to just focus on two basic: ischemic stroke and hemorrhagic stroke. So what happens? In ischemia, there's a clot happens inside the blood vessel that's supplying the brain that carries the oxygen. So this is how there's a cut down of the oxygen to the brain. So that's called the ischemia. So ischemic stroke happens. And God forbid, and sometimes what happens, the blood vessel get ruptured. So when it happens, the part of the brain cannot get blood again, because cannot get the blood, and then there's no oxygen supply to the brain. So what happens? So again, there's a hemorrhagic stroke. Do now you understand ischemic stroke and hemorrhagic stroke? So these are two main strokes I want to talk about. So how ischemic stroke happens? It can be emboli, it can be thrombus. How it happens? When there's a fatty deposits happen, it can cause it. high cholesterolemia can cause it. So there are many causes of ischemic stroke, and how patient can have hemorrhage. The most important cause is the hypertension. Patient can have a brain aneurysm. So there are multiple causes. I'm just talking briefly about it. So again, as I mentioned, hemorrhagic stroke, whenever there's a break or rupture or burst of the blood vessel in the brain cell. So which damages, whenever this rupture happens, so what happens? There is no blood supply. So what is aneurysm? So aneurysm basically is a balloon-like bulge in an artery that can stretch and burst. Like this is the blood vessel, and the balloons happen. Like this is the balloon-like bulge happens in the blood vessel, and when it gets too much stretch, it bursts. So it can that can cause a hemorrhagic stroke. So you might heard of the mini stroke. What is a mini stroke? So mini stroke basically call it TIA. So TIA is called transient ischemic attack. Means for a short time. It basically is a warning stroke. It is very important to know about it because it's a warning sign to happen a full-blown stroke for in the future. So it's also a medical emergency that we need to take care of it to avoid any major stroke in the future. All right. So it's a TIA, that's transient ischemic stroke, same like the ischemic stroke. But what happens, blood clots is the same happens like blood clots, but it happens for a very short period of time. That's called transient. And more than a third of the people who have a transient ischemic attack, if they don't get treatment, if they don't have, it can lead to the major stroke within 1 year. And there's a study that tells us that about 10 to 15% of people will have a major stroke within 3 months, the one who already have a TIA or transient ischemic attack. So I will go over pretty quick about the CT scan. So this is a normal CT scan. Again, in the CT scan, this is the left cerebral hemisphere. This is the right cerebral hemisphere. So this is a little bit, you have to understand the anatomy, first of all, left, and this is right. And you can see the other part of the brain anatomy, the caudate. What is caudate? So basically, caudate is a nucleus function, and it's not only it helps, but the function of the caudate nucleus is basically not in the planning, in the execution of the movement, but also it helps in learning, memory, reward, and motivation and emotion. So caudate plays a vital role. And then you can see the putamen here. So what is the function of putamen? It is also involved in the learning and motor control of our body, and also include the other functions: speech, articulation, language functions, reward, cognitive functioning, and these are the main function of the putamen. And then you can see the globus pallidus here. The primary function of globus pallidus is to control the consciousness and the proprioceptive movements. All right. So this is briefly about, this is how the normal CT scan looks like. This is the left cerebral hemisphere. This is the right cerebral hemisphere. This is the normal CT scan, how it looks like. So now let's go over the next slide, please. So this is, again, you can see over here, left cerebral cortex, right frontal lobe. This is the cranial, caudal. This is the normal, you have idea how it looks like. So let's move on the next. So what is a hemorrhagic stroke? We talk about acute hemorrhage in the brain. It can rupture the blood vessel. So what happens? So now this is the blood vessel, and you can see the rupture happen. So how it looks like in the CT scan. So in the CT scan, you can see this is the hyperdense area of the brain. This white area you can see, right? So what side is this? I told you, right? This is the right side, and this is the left. So you can see on the right side of the cortex is the hyperdense area of the brain. So what happened here? So whenever there's a blood vessel rupture, so on the CT scan, what happens? The hemoglobin get accumulated. Whenever there's acute hemorrhage, so what happens? There's accumulation of the red blood cells. And that the accumulated hemoglobin appears bright on the CT scan. That's why we can see this hyperdense area of the brain, and you can see it's a cerebral hemorrhage. So now how the ischemic stroke looks like. So next slide, please. So this is, you can see this ischemia, how it looks like. So ischemia we talk about occurs when there's a blood clot known as thrombus or blocks or any clot that can cause it. So how it happens? So when there is and you can see there's a hypoattenuating brain tissue. So in that, you can see hyperdensity in the stroke hemorrhage, in hemorrhagic stroke, and ischemic stroke, there's a hypoattenuating area on the brain, on the CT scan of the brain. And I will go over briefly, what are the signs of ischemic? What are the signs of stroke? It can be ischemic, it can be hemorrhagic. It can be, the patient can present with a sudden numbness in the on the facial side, on the right of the face, or arms, legs. Sometimes patient present with the weakness of the face, arms and legs. Sometimes basically it's on the one side. So what happens is the contralateral. Like if symptoms are happening on the right side, so there is a mostly affecting the left side of the brain. So this is how we have to understand how it works. And some other symptom, patient can get confused. They have trouble speaking. They have trouble articulating, understanding the speech. Sometimes patient have trouble seeing if a stroke happening in the posterior, in the occipital lobe area. And also sometimes there's a sudden trouble with walking and balance. These are all the main symptoms we can see in the stroke. All right, so let's talk about the case study pretty quick. So let's see who can read this for me. Minahil or Robin, can you read this for me, please?
I can read it for you.
Sure, go ahead.
Sure. So we have here a
Can you introduce
60
yourself first, please?
Sure. Yes, sorry about that. So we have here a 65-year-old female who comes to the ER with a right arm and right leg weakness that started at home. The patient here has a history of hypertension, atrial fibrillation, hyperlipidemia. No family history of stroke. On review of the system, the patient complained of a weakness and some slurred speech. The other review of the system is negative. The vital signs are stable. On examination, the patient has a right upper extremity, left upper extremity weakness, and a 4 out of 5 strength. What is the next best step in diagnosis? So we have here an echocardiogram, carotid Doppler, CT scan of the brain without any contrast, a lipid panel, check the TSH, or check the A1C.
Good, thank you. So can you guys tell me, can you type in or tell me what do you think, what should be the next best step?
I'll try my best. So let's see. I would say check a CT scan of the brain without any contrast.
Good, very good. Yes. So as we were talking about the CT scan, right? So there's the reason I
Yes.
brought this up. So any patient comes in, we have to, in the emergency department, of course, a patient is an emergency situation, I talk about it. It can be hemorrhagic stroke or ischemic stroke, right? So what we have to do
Yes.
next? First step, patient comes in, we go talk to the patient, we do stat CT scan, but we see without contrast. Why? Because we have to exclude, first of all, is a hemorrhagic stroke or ischemic stroke. If it's a hemorrhagic stroke, we don't give the contrast to the patient. So that's why we do without contrast to make sure it's not a hemorrhagic stroke. So most of the time it's a ischemic stroke, but of course we cannot we have to rule out first the hemorrhagic stroke. And then the other options I talk about, the echocardiogram, carotid Doppler, lipid panel, A1C, TSH. So first of all, let's talk about CT scan. So as I showed you in the images, how it looks like an ischemic stroke, how it looks as a hemorrhagic stroke. So as I mentioned, most common is a ischemic stroke. So then we see, okay, sometimes there's a less sensitivity. The CT scans have a higher sensitivity to diagnose the hemorrhagic stroke and less sensitivity to diagnose the ischemic stroke. But first of all, CT scan will rule out the hemorrhagic stroke and we see, okay, there is no ischemic stroke. So what to do next? So next step, we do the MRI of the brain. That is more sensitive to diagnose the ischemic stroke. And then this is the next step. I'm just telling you in the management, how we do manage the ischemic stroke patients. And then, of course, hemorrhagic stroke is a different story. There's a vascular surgeon we get involved and all this. So let's focus on the ischemic stroke. So then next step is the MRI. So the MRI of the brain, we see, okay, there's a one area that is, I talk about hypoattenuating area. So this means patient has ischemic stroke. So we'll see which area. So then what we do? So we have to give, I will not go in detail the management. We give some antiplatelets, aspirin, Plavix is the initial medicine we give. So then we admit the patient. So after admission, what we do? We find the cause, why patient have the ischemic stroke. So these are all the mentioned echocardiogram, carotid Doppler, lipid panel. So these are all the tests we do. So we do all this, but as a first or next best step when patient comes to ER. So don't forget that, of course, these are all can be all the options, but the first thing should be the CT scan. And when we admit the patient to rule out, to figure out what's going on with the patient, so what we order? We order the echocardiogram. Why? Because if you see in the history, we mentioned the atrial fibrillation. So atrial fibrillation is the condition in which patient's heart beat irregular. Like normal heart should beat like this, 72 per minute normally, it can be go up and down. But what happens? This is the atrial fibrillation, like this. Normal heart, I told you, like this, contract fully, but atrial fibrillation is like this. So it can cause the clots in the heart chambers. As you know, there are 4 heart chambers. I will, sometime when we talk about the cardiovascular system, I'll talk more about it. So what happens with the atrial fibrillation? It can cause the clots, and those clots can go to the brain. It can cause the ischemia. So that's why we need to get the echocardiogram and make sure there's no thrombus sitting in the atria or ventricles. Then the carotid Doppler. Why we do the carotid Doppler? As I told you, the main blood supply comes from the 2 main sources, internal carotid artery and vertebral arteries. So carotid Doppler, we check to make sure there's no carotid artery stenosis. That can cause the stroke as well. Then the lipid panel, as we talk about some clots, how clots build up. These are when there's a hypercholesterolemia or high cholesterol level, or so these are hyperlipidemia can cause it. Then A1C, why we check the A1C? To diagnose diabetes and the risk factor. Then the TSH. So these are all the risk factors we figured out why patient had the stroke, so we can manage accordingly. So I will not go in detail the management. I will stop here, and I will pretty quickly talk about the neurotransmitters. So there are many neurotransmitters, as Robin and Minahil talk about it. So briefly, I want to talk about what are next. Okay, yes, here we go. So neurotransmitter, you can see the synapses and brain, how it works. So what is a neurotransmitter basically? It's a chemical substance. You can see how complex our brain is. You learn the anatomy, the blood supply, the chemicals we release from the brain. So there's a chemical substance. What is neurotransmitter? A chemical substance that is released at the end of the nerve fibers, and how they get released. So it's basically the chemical messengers that help nerve cells to communicate with each other. So you can see over in this diagram how they're communicating. The nerve cells are communicating with each other. And I will just talk briefly about the happy hormones. Why I'm talking about it? Because as a student, as a physician, we all get stressed out. So I always tell my patients, smile. So what happens when we smile? So all of you, please smile at this time. So what happens? We have 43 muscles on our face, facial muscles, and we talk about the nerves. We talk about that convey message to our brain, and happy hormone release from our brain. So I will just talk about the happy hormones that I call the happy neurotransmitters, the dopamine. Dopamine, serotonin, endorphin, and oxytocin. These are the main hormones for happy, the multiple neurotransmitters. These one I'll talk about. So whenever you get stressed, just smile. I told my youngest one, she's 8 years old, I said, smile. She said, okay, this means you want happy hormone. I said, yes. So it's very important. I tell all my patients, let's talk about briefly about a neurotransmitter, dopamine, endorphin. So what is endorphin? It's one of the neurotransmitter released from the pituitary gland and hypothalamus in the brain. So these are two structures in the brain that release the endorphins. And it's a natural hormone, it's a natural happy hormone that can alleviate the pain. It can reduce our stress level. It can help us improve our mood, and it enhance our sense of well-being. So these are natural hormones sitting in our brain. What we have to do? We have to just activate our facial muscles and convey the message. Even we are stressed, we don't want to just give a fake smile, because brain cannot distinguish between the fake smile and the real smile, because when we smile like this, I'm smiling at this time. So what happens? The facial muscle convey the message to my brain that I'm happy. And that message to pituitary gland, hypothalamus release endorphin hormone, right? So it will reduce my stress level. I will feel good. I feel good sense of well-being. So that's the reason, that's the function of the endorphin. Then again, next is dopamine. It's also called the feel-good hormone as well. So dopamine is another neurotransmitter, and basically it lies in one of the nucleus called nucleus accumbens and in the prefrontal cortex. And again, it's associated with the pleasing sensations, associated with the learning, memory, and much more happy hormone. And then oxytocin is again a natural hormone that manages key aspects of female and male reproductive system, and released during the lactation as well, when the breastfeeding moms, and as well as aspects of the human behavior. So what controls it? The hypothalamus, that makes the oxytocin. So now you can relate which part of the brain release which neurotransmitter. And now the last but not least, the serotonin. It's also called the 5-hydroxytryptamine. It's a monoamine neurotransmitter. And you already in the biochemistry, undergrad students, you might be learning about it. So its biological function is very complex of serotonin. So what happens? It has multiple functions. It helps with our mood elevation. It helps with our cognition, reward, learning, memory, and numerous physiological processes. So whenever patient is depressed, we give the antidepressants, and most importantly, the SSRI. You might have heard of the SSRIs, serotonin release inhibitors, that we give to the patient to help them increase the serotonin level to help patient get out of the depressive mode. So how we can, so basically I brought these happy hormones for you specifically. So why? Because when we're studying, when we're seeing the patients, when we're overwhelmed, we all get overwhelmed. It's natural, right? And medicine field is very, I would say, too much effort we need to put in, a lot of sacrifices we do, but it's very rewarding profession. So you have to take care of yourself as well. So every time I talk, I just talk briefly about self-care. So you have to smile 3 times a day. I tell my patients as well, minimum 3 times a day. At the end, I tell them, give me a smile. So say, we are sick and she's telling us smile. I said, I tell them, good hormones from the brain. And you heard laughter is the best medicine. And then every time I go and see them, without asking me to give me a smile, that this doctor has to ask or give us a smile. And when I tell them, whenever you smile, I smile. So you're keeping me healthy as well. So smile, it's very good. Please smile. Make a habit to give smile to your friends, your parents, your siblings, and keep yourself healthy and everyone around yourself, you to be healthy. And how we can promote there are many factors that you can promote the production of happiness. How we can get it? By doing exercise, by fulfilling the activities. And or you can say the light exposure of sunlight can give you these happy hormones. And focus on the eating foods, healthy food, because that is a high in the tryptophan. Tryptophan is very rich in these, they can cause release of these good happy hormones. And of course, playing, doing exercises, meditation. So these are all the natural ways you can get the happy hormones. And pretty quick, I'm going to talk about the self-care. Again, 4 areas: physical health, mental health, your emotional health, so your spiritual health. So please focus on self-care as well. And then last but not least, I will talk about your keys to success. You already saw this slide before as well, but again, your passion and profession should be the same. So I always tell my students, whenever your passion and profession will be the same, you will not work even a single day. Because Saturday morning over here, and most of you are watching live, you woke up this morning, you want to attend the session, you want to ask the question, why? So you are passionate about it. So when you're passionate about it, you're out of time and space. I always give the example, like we watch the movie that we like, we complete out of time and space, and time flies with 2-3 hours flies so fast. We say, we just started watching the movie and 2 hours are gone, right? Why? Because we're out of time and space. And most importantly, be persistent and never give up. So I give example to undergrad students. If you want to be in, of course, you will face a lot of struggle, hard work. I know biochemistry is very tough. I understand many students do struggle, but never give up. If your GPA is low, go do masters, go do PhD program, and then keep applying. Doesn't matter how many gap years you're taking. You will hear the stories that many students don't take a gap year. So don't get overwhelmed. Oh, they're very smarter than you. No, what they did when they were undergrad, they didn't waste much of the time in socializing. So now, but it's okay. Socializing is good. I mentioned about it, physical health is one of the important part. You need socializing. But again, I have seen the students, they get 3-4 gap years and then get in the medical school. And it's very rewarding profession. If you want to do it, please do it. Be perseverance and grit and have a growth mindset. And always say, practice, practice, practice. There's no magic in this world. And never give up. If you decided that you want to be in med school, you want to be a physician, you want to serve the community, go for it. And if someone may ask me, Dr. Shima, you have, but if you want to give an option, what do you want to be? I want to go in med school again. And I tell my kids, they say, oh, you're crazy. I said, yeah, there's a lot of effort, a lot of sacrifices, but I want to do it again. And sometimes when I see the curriculum of med school, oh, I wish I want to do it again. I want to go to be a med school student again. I want to learn. But again, I would say it's really rewarding profession, because every time we learn something new, And if you want to learn something more, it is up to date. There's always new guidelines there. We do follow as a physician, and please keep yourself up to date and never give up. And most importantly, there's always help available. So if you have any questions, I would like to, you can send email to TeleShadowing. They will send it to me. I will, if you want any question that really want face a person-to-person session, I would like to do that. And please feel free to connect with us. And there's a lot of help available. And please don't give up. All right, thank you so much. I'll stop here. If you guys have any questions, you are welcome. Thank you.
Thank you so much, Dr. Chima and Robin, for a wonderful session today. I know I learned a lot personally as well. The link to the TeleShadowing quiz is now live. You'll need a 70% or higher to pass and receive certification for today's session. Today you'll receive 2 shadowing hours because we had a physician with us today. It'll be on teleshadowing.com/certification. And next week we'll be learning a little bit about psychiatry. That'll also be a 2-hour-long session where we'll go over the basics. We'll talk about a mini mental status exam, things like that. So I'm looking forward to seeing you all next week. Take care.